Hey guys, it's Dr. Mackey. Let's keep going. Hemorrhage in trauma, policy 8065. So when we talk about these policies, we want to make them digestible and easy to remember. This one starts out reminding you about kids. Pediatric patients are 14 years and under. If any of them have a tourniquet on, they go to a pediatric trauma center, which is UC Davis. If that same pediatric trauma patient doesn't have an airway and you can't establish an airway, they go to the closest facility. If that pediatric trauma patient has an airway but is under CPR, then you go to the closest trauma center. It doesn't matter if they're pediatric or not. It also reminds you in here, if you put on a tourniquet, don't forget to document the time of application of the tourniquet in the PCR, ideally on the tourniquet itself, or you can write it if you have like a pen on the patient's extremity or on their clothes or somewhere where it's easy to read and find, and then also communicate it to everyone who's going to take care of that patient. Okay, let's move to the second page of this policy. The second and third page really deal with compressible and uncompressible hemorrhage. Most compressible hemorrhage obviously is extremities, head, neck, and sometimes the torso. If you can compress it and apply direct pressure, ideally fingertip pressure initially, not just using a bandage, but using your fingertip as well to stop bleeding, then you can apply that pressure, control the bleeding, and then follow your trauma policies and trauma destination policies if they apply. If you cannot control, the next step is going to be using hemostatic gauze. And if you can't control it from there, you need to make a decision if it's extremity or not. If it's extremity, that's where the tourniquet comes in place. You're going to apply it 2 to 3 inches proximal to the wound, tighten until there's no more bleeding, and then document the time. If it is not an extremity, you can't get a tourniquet on it, and there is no hemostatic gauze or their bleeding is still uncontrolled, then you just continue to maintain direct pressure, and that would be rapid transport to a trauma facility. All right, so occasionally we'll come across patients who have had tourniquets applied either by lay public or by law enforcement that is either not an approved tourniquet that we wouldn't use, or it's in the wrong place, and more often it's not an approved tourniquet, so someone may use a belt or a shoelace or something like that. What you're going to do is you're going to, in that situation, position your tourniquet proximal to the wound and then remove the inappropriate tourniquet and assess for bleeding. If there's a resumption of bleeding, then you're going to tighten that tourniquet until the bleeding stops and do your documentation. All right, let's move on to the big daddy, TXA. So these are going to be patients with blunt or penetrating trauma to the torso. So this is going to be chest, belly, penetrating or blunt trauma with signs of hemorrhagic shock, including systolic blood pressure less than 90. In these patients, we're going to administer TXA. The trick is you got to think about it early, and you have to know how to mix it. Okay, so here's the big things about TXA. It has exclusion criteria. We already talked about inclusion, which is blunt or penetrating trauma to the torso with signs and symptoms of hemorrhagic shock. Exclusion criteria: greater than 3 hours since the injury, isolated extremity trauma, neck or head. Obviously, we're using tourniquets for the extremity trauma. And these questions are harder, and sometimes the patient won't know, especially sick trauma patients. They're not going to answer if they had a stroke or an MI in the last 24 hours. Most have not. If they've had traumatic arrest greater than 5 minutes, with greater than 5 minutes of CPR without ROSC, they can't get TXA. Cannot. Hypotension secondary to cervical cord injury, so neurogenic shock. These patients are going to be hypotensive, but they'll also be bradycardic, remember. And then it's not approved in PEDS patients at this time. So if they don't meet any exclusion criteria, they meet inclusion criteria, then you give them TXA. This is very simple. It's 1 gram, which is 10 cc's, into 100 milliliters of D5 or normal, and you infuse it over 10 minutes. Very, very simple, easy to use. We are going to work together on the actual administration, mixing and administration of TXA, but I wanted to review it here. Okay, that covers hemorrhage and trauma. We'll see you on the next one.